Okay, let's go ahead and fire up the engines here. So we are starting chapter 6. So we're looking at skeletal tissue, skeletal system. Okay. So we're going to take a look at, this is kind of the tissue, the bone physiology chapter of the skeletal system. And so when we take a look at this, we're going to take a look at the structure a little more closely, kind of dig in a little bit to more of the nuances of the bony tissue. So we kind of held that off. We kind of did a little bit of a light treatment of it in the last chapter. And so now we're going to dig into it a little bit more. And so we're going to be taking a look at the structure. So compact bone, spongy bone. We're going to be taking a look at the functions of the skeleton and of bone itself. And then we'll kind of move on from there. So let me kind of start with the functions. A couple of these functions you guys pretty much know about, right? So oftentimes when we take a look at functions, we will oftentimes come up with the support idea, right? So it's hard, it's a rigid type of a matrix, but it's supportive, right? So we think of it as supporting our frame, kind of giving our body a framework and a shape. For cartilage, it's flexible, so you have a little bit of pliability there. And it's also for connection. So they're all kind of supportive processes, kind of depends on sort of the hardness of that particular tissue as to what specific level of support it basically adopts. But it's all kind of supportive. We tend to sort of identify the skeleton with support. It's also a protective sort of a thing, like for instance, not so much our long bones, but certainly we identify the skull bones as protection. So basically it's like our little football helmet protecting our brain. Our ribs and sternum are protecting our thoracic cavity. And so protection is certainly a big piece of it. And oftentimes we identify it with movement, right? So basically it allows us to be able to move our frame when we string it up with ligaments and muscles, and allows us to be able to be ambulatory, right? So support, protection, ambulation, those are all things that oftentimes you pretty much can access pretty easily. You can just ask Joe Average on the street and they'll probably come up with one of those three. The ones that we typically don't really think of in terms of bone are what I call the physiological functions. So for instance, bone is our main storage area for calcium, which we need, and also phosphate. And so we also have adipose tissue, some fat. It's not our main fat reserve, obviously, but we do have some fat storage as well in our bone marrow. And so sometimes we don't think of bone as being a storage unit for calcium and phosphate, but it is indeed. And the other one that we don't really think about oftentimes is our blood cell production, right? So in our bone marrow, we get our blood cells and our platelets being produced in our bone, in our bone marrow. And so there's a lot of different functions. Probably the most important functions of the bone are oftentimes physiological, oftentimes the ones that we tend not to think about. So before we kind of talk about bones, it's appropriate to talk about sort of the half sibling, if you will, and the support connective tissue of bones, and that's cartilage. And so cartilage we talked about a little bit already. We know already from the last chapter that we have three main types of cartilage. We have hyaline cartilage, we have fiber cartilage, which is that tough cartilage associated with the pubic symphysis and the vertebral discs. And of course, we have the elastic cartilage, which is our ear. And so we already went over that one. And we also went over the cells of cartilage, right? So the chondroblasts are going to be laying down new cartilaginous matrix. The chondrocytes are mature cells. These are the ones that we see inside the lacuna, that little hollowing area that's associated with the cartilaginous matrix within which the chondrocytes live. And so these guys are in those little hollowing areas, and they're basically maintaining. So these guys will kind of be the maintainers. They maintain that cartilaginous matrix. And then along with the cartilage, and we talked about this a little bit, but we didn't really dig too deeply into it. We just sort of mentioned it in passing. The structure of cartilage is certainly you have matrix, but then around the matrix, you have what's called the perichondrium, which is a liner. Peri means around, the chondrium, the cartilage. So this is basically a double layered sheath or a liner of connective tissue. And so it covers the cartilage, except for at the points of articulation. So the cartilage that's in your joints, you don't have perichondrium in them, but all the rest of the cartilage you do. And the structure of the perichondrium, and I like to kind of dig into a little bit more of the structure of the perichondrium at this particular point, because some of the patterns that we see in the construction of cartilage are basically patterns that we repeat in the structure of bone. And some of the physiological functions that we see happening in cartilage are very paralleled in bone. And so this is kind of like our introduction to some of those patterns, and then we'll reinforce those when we get to the bony tissue. The perichondrium is a good example of that. So the perichondrium basically is going to have two layers. It's going to have an inner layer, which oftentimes is what's called the cellular layer. So it's kind of a little bit more like the physiological layer. It's going to have chondroblasts in it, lining this layer. It's not going to have a whole lot of fibers. This is not your tough portion of your perichondrium. It's your cellular layer. And then you have the outer layer of the perichondrium. And so here you're going to have where blood vessels and nerves will penetrate. You don't have blood vessels in the cartilage itself, but they will basically kind of wrap around the perichondrium. So they're kind of around the periphery. And then, of course, you have connective tissue in that area as well. So articular cartilage, that is to say, the cartilage in joints, basically is like a cover. It's kind of like a Teflon cover at the tips of joints. These typically won't have perichondrium, and so as a result, they're not growing, and typically they're not replaceable, because your point of replacement, like we mentioned before, that your cartilage is slow in terms of repair, and the reason it's slow in terms of repair is because it's lack of nerves and blood vessels. But if it doesn't have any perichondrium, you simply don't have the chondroblasts to be able to rebuild or to relay down the cartilaginous matrix, which is one of the reasons why articular cartilage generally wears away and you don't get it back. So we have a couple of different types of growth patterns when we take a look at cartilage. And we see these same types of patterns repeating themselves when we actually get to bone as well. So first of all, there's appositional growth. And appositional growth is when you're laying down typically new matrix, and it's happening at the periphery. So when you're kind of laying it in the outer edges. That's appositional growth. Interstitial growth is typically, so this is kind of like a layer, like an outer layer. So like if you have a piece of cartilage like this, if you're laying it on the outer layer, that's appositional growth. Interstitial growth is happening, and the important piece here is within the tissues. And so what happens is they start to lay down matrix within the tissues and between the cells, and then basically your cartilage kind of grows from within. And so those are two different growth patterns. You can either layer it or you can kind of build it from within. And this is kind of what it looks like. So here's an example of our hyaline cartilage. So you can see the chondroblasts that are basically on the inside of the perichondrium. So the perichondrium is this portion, this outer portion right here. The cellular layer is this little layer, and then the connective tissue layer is the outer layer. Now, appositional growth is happening where these chondroblasts are laying down new matrix. So as they lay down new matrix, basically what's going to happen is the cartilage is going to start to grow outward. So you're going to basically just lay one layer on top of it, you're going to lay another layer on top of it, another layer, and another layer, and another layer, and basically you continue to grow layer by layer in an outward fashion. And so that's the appositional growth. However, if a cartilage cell is starting to lay down cartilaginous matrix within the tissue, that's interstitial growth. So it's happening within the actual and between the cells themselves. So here you can see hyaline cartilage where you get a lot of this interstitial growth. That's mostly what you guys were noticing and recognizing when you looked at your hyaline cartilage slides, especially your trachea slides, that kind of airbrush, kind of glassy look of the hyaline cartilaginous matrix. And so when you are looking then at cartilage in terms of like a developing bone, you also see hyaline cartilage. And we'll talk more about this. It's called endochondral ossification. And so what we see in a growing bone, so this is like an infant bone, fetal bone. We are basically a cartilaginous skeleton at the beginning. And so what you have basically is multiple regions. So you have regions that are at the tips of the bones. These regions are what's called the epiphysis. And then the center portion of the bone is the diaphysis. This is basically what will become the shaft of the bone itself. And then generally speaking, all of this is hyaline cartilage and the epiphysis. And so that's basically what you see in fetal bone. Now, as you get older, your bone starts to look like this. So this is a femur. And so you'll see that your articular cartilage is simply just a little strip that's right at the tip. It covers the bone as it articulates with another bone. In this case, the head of the femur is articulating with the hip by way of snuggling into the acetabulum, which is a little kind of a bowl-shaped hollowing for your ball and socket joint in your hip. It's composed of the fusion of a couple of bones. But the articular cartilage is basically designed to reduce that wear and tear of bone-on-bone grinding, right? So if you had bone-on-bone grinding and you didn't have that articular cartilage there, your bones would probably wear away pretty quickly. It's kind of like a millstone grinding away at grain. So it's there for that reason. Okay, now let's take a look at the histology and the physiology of bone. And let's focus in, first of all, on the bony matrix. So we talked a little bit about cartilage. We talked a lot about matrix, the different components of matrix. We talked a lot about ground substance and the different things that are in ground substance. So at this point, you guys should have a pretty good feel for the components of especially connective tissue matrix. And so what we really want to do is we want to use that information that we have already, and we want to compare it to what's so special about bone, right? Because even with cartilage, if you look at it, I mean, it's so pliable, cartilage is, especially the hyaline cartilage, that really it seems like it's more related to like the connective tissue propers really than to something really hard like bone. Bone really seems like to be a little bit of an outlier when it comes to connective tissues. So the question is, what's in its matrix that makes it so different? Well, it's got a couple of components to its matrix. The first piece to bony matrix, roughly about a third of it or so, is going to be organic. So you're going to have lots of collagen in your matrix and lots of proteoglycans in your matrix as well. And remember, proteoglycans along with hyaluronic acid is essentially how you capture fluids and moisture. And so that's about a third of your bony matrix is organic. About 2/3 of it, however, is inorganic. It's actually composed a lot of what's called hydroxyapatite, which is essentially this large sort of calcium phosphate hydroxide crystals composed of lots of phosphates, lots of calcium, and these crystal-like structures. And this actually becomes the curing agent for bone. And so these two together will give you your hard bony matrix, and that's kind of where you get your calcium storage and your phosphate storage. So for instance, if you were to remove the mineral component from bone, it would be basically too flexible. For instance, if you take a bone, it looks like this one is the fibula, and you take out the hydroxyapatite, what you're going to end up getting is this like little noodle-like bone that you can kind of wrap around your finger, and basically it just becomes too pliable. You can't walk on something like that, right? So it's like walking on noodles. Now, if you take out the organic piece, especially the collagen, then what you get is really brittle bones. So the collagen basically prevents the brittleness. So all hydroxyapatite makes it too brittle. All collagen makes it too flexible. And so you have to kind of a mixture of the two organic and inorganic pieces in order to be able to get the perfect structure of the bony matrix that we want. So when we take a look at the cells, it still follows the same pattern that we saw with cartilage, right? So we have our osteoblasts, basically, which lay down new bony matrix. And that new bony matrix is what's called osteoid. This is uncalcified bone matrix. So it hasn't been set up yet. So it's not hardened yet. And the osteoblasts are the ones who are responsible for osteogenesis, right? So this is basically that initial ossification of your skeletal system. And so typically what will happen is in these cells, you'll have obviously your organic material, your collagen, and things of that nature. And then that'll be released out of the extracellular matrix. And then you'll also have hydroxyapatite precursors stored in vesicles inside the cell, ready to be released by exocytosis. So you have all the components of your matrix inside these cells. And so they release both of them, and it's kind of this mixture of bony matrix that will then calcify and solidify into hard bone. So ossification basically is the term that we use for the formation of bone. That's basically what it is. So the osteoblasts basically are laying down the bony matrix, and they surround themselves with the bony matrix. And then as they surround themselves with the bony matrix, they basically carve out a nice little space for themselves, the lacuna. And your osteocyte basically is living inside this lacuna. So the osteocyte, remember, is a mature bone cell, and its job is to maintain the current bony matrix. And so as it starts to ossify, and as it starts to load down, so here's your little osteocyte. So as it's laying down the matrix on the outside of itself, it's going to start to fill up and surround itself with this hard bony matrix. But what it does is it leaves a little space for itself. That's the lacuna. And in addition to that, it also leaves like little canals. It opens up little canals for itself. So basically these little canals allows it to be able to breathe and to gain nutrients. So for instance, here's an electron micrograph of an osteocyte. So you can see here's the nucleus, basically this large structure right there. That's going to be the nucleus of the osteocyte. And then this little space right here, the white space, is the lacuna. And then you can see these little extensions here forming like these little canals. Those are what's called the canaliculi. So really what the osteocyte does, these are all basically not conduits, but the osteocyte, instead of just looking like a cell, actually looks like a little octopus. It basically sends off these little sort of projections away from itself, extensions, if you will, tentacles of sorts, which are evaginations of the cell membrane. And as it does that, it kind of forms these little trailing tentacles that will then reach out so that it can get blood supply And then as it's basically dumping bony matrix around it, it'll form these like little hard bone canals. So you'll see, here's your lacuna, and this little bony channel, like a little tunnel that kind of goes through there. And it basically forms these little openings that allows these little projections. For some reason, I feel like drawing tonight. But these little bony projections like this. And so this is all bone. That's all the bony matrix. And so these little extensions then become canaliculi, little tiny canals that allows the osteocyte to be able to collect nutrients and things of that nature. So these little tiny canals are basically inhabited by these little cell processes of the osteocyte. So here's the osteocyte nucleus itself. So nutrients basically come to the cell by these little canaliculi, these little cell processes that are basically tunneled through the bony matrix. So the third type of bone cell that you're going to see in the bones is going to be the osteoclast. Now, we have talked about the clast cells before, but the clasts really have a really big role. And so what osteoclasts will do, so osteoblasts lay down new bony matrix. Osteocytes maintain existing bony matrix in existing cells. Then osteoclasts, basically, they will essentially what's called resorb bone. So they'll take bony matrix, and then what they'll do is they will basically break that bone down, and they'll release the components of the bone structure into the bloodstream. So they will resorb the bone. Resorption of bone basically means to break it down and release into the bloodstream. So as a result, typically, you'll see kind of at the edges of bones, this kind of like ruffled border. It's like a pitted border. That's where the osteoclasts are hanging out. And so what happens is the way they break down bone is they take hydrogen ions and they pump it across the membrane into the space. And so this basically, if you remember your 1080, right? Hydrogen ions is basically what makes acidity. And so when you pump hydrogen ions into the space, it forms an acid, and the acid basically kind of dissolves away the bone and eats away the bone. And so it also will release enzymes that basically will digest the protein portions of the bone. And so your osteoclasts are actually derived, they're descended from monocytes. If monocytes are a type of white blood cell, so these are phagocytic. And these are formed from red blood cells from the red marrow. So an important role for your red marrow, which is one of the reasons why it's hidden deep inside your bones, protected from outside injury or outside insult. These osteoclasts oftentimes are multinucleated, so they're carrying multiple nuclei, usually because of a fusion of multiple cells. Now, whenever you see a cell that has multiple nuclei, usually there's two things that happen, the two reasons why a cell becomes multinucleate. First of all, within a cell, when you're going through cell division and you duplicate your nucleus, there's a point at which you essentially have your two nuclei, and now you need to separate the cell. You guys will probably remember this from your mitosis chapter in 1080. But here's the thing. If you don't do cytokinesis, then what's going to happen is you're going to basically be a cell with two nuclei in it. So cell division without cytokinesis will give you cells with multinucleated cells. A lot of what we see in physiology, however, is the second mechanism, and that's the fusion of cells. And so we see this a lot, especially like in muscles, right, where you have one cell with one nucleus, another cell with another nucleus, and what happens is they fuse together. So they kind of fuse together to kind of create this gigantic megacell with multiple nuclei in it. Now, the mesenchymal cells do this. These are also how they derive muscles, and we'll talk more about that in the muscle chapter when we get there. But essentially, what you have is this stem cell early on, right? It's called a mesenchymal cell. It's what we refer to as, it's a specific type of mesenchymal cell, which is basically an embryological stem cell. And we refer to it as an osteochondral. So it's basically a bone cartilage progenitor cells. So essentially it will become either chondroblast or osteoblast. That's why it's called an osteochondral progenitor cell. This is like the patriarch, if you will, right? The ancestor of the chondroblast and the osteoblast. So all of the cartilaginous cells come from the osteochondral progenitor cells, and all of the bone cells come from the osteochondral progenitor stem cells, with the exception of osteoclast. So this is kind of what it looks like. So this right here is your osteoclast. And so you can see it's got multiple nuclei here, 4 of them. And then it's got this kind of ruffled border. And it's kind of inhabiting this little bone pit. And so what's happening is it's basically spitting hydrogen ion out into the space, and that hydrogen ion is basically digging away at the bone and breaking that bone down. So this is a good micrograph of an osteoclast with its 4 nuclei in there and that little compartment where it's kind of digging away at that bony pit. Okay, we'll talk a little bit about the role that osteoclasts play a little bit later, because at this point you may be wondering, okay, so osteoblasts I get, you got to lay down new cartilage or new bony matrix. Osteocytes I get because you have to basically maintain it, but osteoclasts don't make a lot of sense, right? Because then why would you want to have an active process that's tearing your bones down when you spend most of your time in life trying to strengthen your bones and build your bones up? So it seems kind of a little counterintuitive as to why osteoclasts would be around, but we'll talk a little bit about their important role and why they're around here in just a little bit. Typically speaking, when you take a look at different types of bone, this is just basically patterns of how bony matrix is laid down. So there's a couple of different versions of this, right? So the first one in woven bone. In woven bone, basically your collagen fibers are kind of laid down in a random orientation. Usually this is the first type of bone that's laid down by the osteoblast during the initial stages of ossification. Like for instance, during fetal development, you're laying it down very quickly, very crudely in woven bone. Growth, for instance, is doing this. Fracture repair does this a lot. So this is basically the cheapest, easiest way to lay down new bony matrix. So that's an important idea. And so you want to do that because like especially during fracture repair, it's important to start laying down some kind of matrix. You don't care if it's perfect just yet. You just want to put something down. So it's cheap and easy. It's kind of like, not the gold standard. It's just a way to get it started. Then what happens after you lay down the woven bone, you go through what's called remodeling. Now, this is where the osteoclasts come in. So the osteoclasts will come in during the remodeling process, and they will basically remove all the old bone, and then the osteoblast will add new bone. So generally speaking, what will happen is you'll take the cheap woven bone, that random orientation of collagen, and you'll then allow the osteoblast more time to lay it down in more smoother, what's called lamellar bone. And so this is basically laid down in sheets. So this is basically the ideal matrix that's laid down in sheets. And so once you then lay down that in lamellar bone is essentially what your mature bone looks like, because you've had the chance to go through remodeling. You get a chance to really lay them down really nicely, and you really take your time to lay down all of these fibers in one direction, so it's very smooth, very uniform. And so you can kind of really meticulously kind of construct this lamellar bone. So you've got, multiple directions and different layers for strength. So you can really build a nice sheet, right? So woven bone is sort of like the cheap way in, and lamellar bone is like the gold standard. This is like the final result. It's kind of like writing a paper. Has anybody ever written a paper and it's like the first draft is sort of like woven bone? It's like you just slop anything on the page just to get your brain working and just to get your brain moving. And it's clearly the cheapest, easiest thing that you can do. You're just trying to get, when you're talking about rough draft, it's like rough, right? It's like first draft is yikes, right? And then what do? You go through and you revise it. You reword things, you rewrite passages, you lay it all together, you make sure it all fits together and all those sentences flow nicely. That's kind of like you remodeling your essay into more of a lamellar type of final product that you actually want to turn in for a grade. Anybody ever gone through that process? Love it, Daniel. Perfect every time, right? So, different people have a different writing process. For me, I was a slopper. I was woven bone at the beginning, and my strength was revising. That was what my strength was, not in putting it down in the first place, but it was just thinking about it and then revising it and rewriting it. And so that was my strength. So I definitely followed this process when I wrote a paper. So the different types of bones then that we can take a look at. We'll start off first of all with spongy, and then we'll kind of dig in to compact as well. So spongy bone, we talked about a little bit already. It's kind of got this sort of trabecular nature. So this is a perfect example of the spongy bone. So you can see it's got all those nooks and crannies in there. These little rib-like structures, these are called what's called trabecula. And then, of course, what that does, it kind of carves up the space inside the bone into all these little nooks and crannies. And then you can have all sorts of stuff in there. Blood vessels can pass through there. Bone marrow can go in there. The fat of bone marrow can be in there. And so this is an actual electron micrograph. It's actually a scanning electron micrograph of actually what real spongy bone looks like. So it literally does actually look kind of like a sponge with those like little nooks and crannies in it. And so you can see when you take a look at bone, this looks like a cranial bone or flat bone, certainly. You can see that you have this zone of spongy bone here where it's got a lot of holes and stuff like that. But then you can see this outer edges here of compact bone. And so we'll take a look at the compact bone here in just a little bit. Now, if I were to take a cross section of the trabeculum and take a look at it end on, this is basically what I would see. So this is an edge on look of it. And so first of all, around the bone, the actual bone itself is going to be a layer of osteoblast cells. And so these guys basically lay down new layers. And then here you can see an osteoclast that's kind of chipping away at those bony layers. And then the structure is lamellar in nature, right? So lamellar basically means layers. And so here you can see your osteocytes that are inside their little lacuna, and they're basically sandwiched in between these lamella of bony matrix, these layers of bony matrix. And then you can see the little canaliculi that are basically interconnecting the osteocytes with their blood supply. And so that's basically what it looks like. It's also very similar to what an osteon looks like in compact bone. But typically, the spaces in spongy bone are going to be filled up with fat and marrow. It's usually covered with a layer called the endosteum. So endo basically means inside. Osteum is referring to bone. That means inside the bone. So it's an inner layer or an inner liner. And they typically tend to orient themselves along stress lines. What we mean by that is an image here of the femur. So here's the femur. We can see that the main lines of stress, your acetabulum would be up here. So that's basically where your hip would be. So essentially you would have stress lines directly moving into the head and moving down that medial side of your femur. But then you also have kind of what's called a lateral stress line that sort of moves along the lateral edge of the femur. And if you notice the main flow of the spongy bone, you can see the spongy bone seems to be oriented in kind of a directional pattern along these stress lines. So you can see here, it looks like it's kind of oriented following this stress line here, kind of gently kind of moving in those directions. And you can see these cells look like they're oriented in this direction. Basically, the idea is giving you a little bit of extra support in the spongy bone area so that these lines of stress are basically well maintained by the trabecula. The trabecula themselves basically act like the columns of a building that's kind of holding up a building. Or like colonnades. And so the idea of a colonnade or a column is that when you architecturally build a column, the idea is to have the column right where the stress point or where the weight is being applied. You don't want to basically build a column with the weight being applied that's not over the column. You want the weight to be applied right on the column, right on the stress line, so that you can hold up the roof. And that's exactly how the trabecula are arranged inside your bones. Okay, so that is spongy bone. Now let's take a look at compact. So compact is solid. There's no nooks and crannies. There's no trabecula. And typically, it's only the outer layer of the bone. It generally is denser than spongy. And you'll have blood vessels, which are basically surrounded by the lamella. And then ultimately, your functional unit is the osteon, oftentimes referred to as the Haversian system. But basically, what you have is concentric rings of matrix laid down around a central canal, which is basically the blood vessel. So here's your central canal, and then you have concentric rings laid down around that central canal. And of course, this is all laid down by osteocytes. So that's your osteon structure. So just like they were smashed together between the lamella and the trabecular bone, they're also smashed between the rings or the lamella of the matrix, and they're interconnected with these canaliculi, just like we saw before. So these little cell processes or these like little tentacle-like structures, which have little tunnels that they go through in order to connect themselves to the blood supply. So the central canals, basically, or the Haversian canals, are generally parallel to the long axis. So that basically means the long axis of the bone. So the Haversian canals or the central canals basically will run parallel to the axis. And then the lamella, as it's being laid down in compact bone, will have three different types of patterns. You'll either have concentric, which basically means you're laying it down in rings. You have circumferential, which basically means you're laying it around the circumference of a circle. Or you'll have interstitial, which basically interstitial means inside or between. Okay, so we'll take a look at each one of those here in just a second. Now, there's another type of canal system that are called perforating or Volkmann's canals. These guys are perpendicular to the long axis. So basically you have your central canal, which is parallel to the long axis, and you have your Volkmann canals, which are perpendicular. So these guys right here would be the Haversian canal system, and this right here would be the Volkmann canal system. And so what this basically does is it allows flow of nutrients and things of that nature to the osteocytes to keep those osteocytes alive. So basically it's all part of the vascular strategy to get nutrients to these cells themselves. So this is kind of what it looks like. So here you can see these are bigger images down here, so we'll take a look at these. So first of all, you can see you have your osteoclasts, or your osteoblasts, which are essentially embedded, we saw this one before, into the bony matrix, and they're interconnected with these canaliculi. So that's basically what we saw before. And of course, you see you've got your osteoclasts, which are basically residing in the layers, the outer layers, the pit area, and kind of creating a little bit of a pit. And of course, the osteocytes, which are basically in the same position as the osteoblasts, only they're maintaining existing matrix, not laying down new matrix. So let's go ahead and take a look at this. So this is kind of what it looks like. So essentially what you're going to see is kind of a blow up of an osteon. So here's our osteon here. And so you can see that basically what you've got is your central canal. This is where the bloodstream is coming through. And then you have your rings of lamella. So this right here is one ring. There's another ring and another ring. And so you have your osteocytes inhabiting the junction between two rings, and they're inside those little lacuna. So when you take a look at your osteocyte, you can actually see you have your central canal here, and you have all these little rings of bony material. And the little dark spots are the osteocytes within their lacuna. And then, of course, you can see all these like little lateral fissures, these little lateral lines, those are kind of canaliculi, allowing those cells to get blood from the central canal and into the osteocytes itself. So when you take a look at the bone, first of all, you see a couple of different things. Number one is the concentric lamella is basically associated with the rings around the osteon. So for instance, the concentric lamella is referring to these little concentric rings around the osteon. The circumferential lamella is basically just around the outer region. So if you take a look on the outer region, you'll see there's a line of lamella right here. So as you're adding layers to this outer region, that's circumferential. It's going around the circumference of the bone itself. And then the interstitial is going to be all the stuff in between. Like for instance, here's one osteon, here's another osteon. All this stuff right here in between, the holes that you're plugging in between the osteons is interstitial. So if I have a couple of osteons, then all this would be interstitial. So if I have lamella in here, filling in these gaps, this is all interstitial. And then the circumferential will be layers that go around the circumference of the bone itself. The other thing to notice as well is wrapping around the bone itself is a periosteum that has the same type of pattern and construction as the perichondrium. So it's got an inner layer, a cellular layer, and then a tough connective tissue outer layer. And so those are important. We'll take a look at those a little more closely as we move along. So basically, osteons are the fundamental unit of compact bone. So you have a blood vessel in the middle of each osteon. That's the central canal, around which you put your rings of lamella. That's your concentric lamella. And then, of course, you carve out your lacunae and your canaliculi so the osteocytes can get nutrients and things like that from the blood. And then around the periphery of the bone, just underneath the periosteum, is a circumferential lamellae. And then, of course, the interstitial lamellae is basically going to be filling in all those gaps in between the osteons. And so that's basically your compact bone. Now then, when you have your perforating canals, remember these are the Volkmanns, right? These are running perpendicular to the length of the bone. And so what these guys are doing is it's basically they are traveling to and from the osteocytes. And so they're delivering nutrients and waste or taking waste away. And they're kind of exchanging interstitial fluid of the lacuna and the canaliculi. So they're kind of coming in there and basically kind of freshening everything up. So they're kind of circulating fluid through those canaliculi and those lacuna to keep everything fresh in there, because you don't want things to start becoming stale and worn out in there, because then the cells are going to start to suffer. And so they're moving through osteocyte to osteocyte through these gap junctions, these channel-like openings that connects one cell to another. Now, when you take a look at the bone anatomy and the structure of the bone, there's a little bit of a topical shift here. So we're going to be shifting now toward the structure of the bone. We talked a little bit about this already. We'll be taking a look at the structure of a long bone. So the structure of a long bone has a couple of major parts to it. First of all, there's what's called the diaphysis. So the diaphysis, and I'm going to draw in my advanced Scooby-Doo bone artistic abilities here. There's my bone, Scooby-Doo style. So the diaphysis is basically the main shaft of the bone itself. Generally speaking, it's mostly compact bone. And within that is what's called the medullary cavity. We'll take a look at this here in just a second. The medullary cavity within it is has a couple of things in it. First of all, there's going to be a lot of blood vessels in there. When you're young, your cavity is full of red marrow for lots of blood cell formation and production, because you're doing a lot of work as a child. You're growing, so your body's actively growing, and so this supports that active growth rate as you're a child. Once you become an adult, you stop growing, and so those demands relieve themselves. So you're not quite as demanding in terms of your blood cell needs and the delivery of oxygen and nutrients and things like that. So you don't need as much. So ultimately, your red marrow, which started out red and is full of red blood cell production, then turns into yellow marrow, which basically, remember, is mostly fat. And so that's in the thigh bones, like the femur and the humerus and things like that. And in other bones, which aren't as big as the humerus and the femur, usually when we say long bones, that's usually what we're talking about. Those are the first two that come to mind. It's kind of varying amounts of yellow and red depending on the bone and the region of the body. The next major part of the bone itself is going to be, so let's put the medullary cavity in here. So the medullary cavity is going to be this big cavity like this. Okay. The next major piece is the epiphysis. You have two of them. So basically it's the tips of the bones. So this is the epiphysis. And you have an epiphysis down here as well. And so these are the ends of the bones. Typically, they're going to be mostly spongy. So that's mostly what they're going to be. So I'll just kind of put a little hash mark in there like that, just to denote spongy bone. And they're going to be covered around and surrounded by compact bone. So the spongy bone is actually embedded inside, or it's inside of it is, or outside of it is compact bone. So the compact bone surrounds the spongy bone. And then in joints, that articular cartilage, that hyaline cartilage, will basically cover the surface. So if it's a joint like this guy here, it'll basically cover that surface. So this would be like articular cartilage. Now, generally speaking, at the interface between the medullary cavity and the beginning of the epiphysis is a region right in here. I'm going to make this a different color on either side. And this is what's called the epiphyseal plate. Or the growth plate. So it's an area of hyaline cartilage that allows you to be able to grow the length of your bones. And typically when you're growing, that is cartilage, so it continues to convert. But when you're an adult, that converts into bone and it becomes what's called the epiphyseal line. So you basically see ossification, and that's the reason why we stopped growing, is because that hyaline cartilage region or growth plate basically ossifies, and then it becomes solid bone. Okay, so now let's go ahead and take a look from the outside in and kind of start moving through some of these pieces. First of all, the periosteum, right? So this is your connective tissue liner, your membrane, your connective tissue membrane, very similar to the perichondrium. The outer portion of the periosteum is typically dense, irregular, collagenous connective tissue. Remember, this is the one that is kind of the pink swirls. So dense, irregular, collagenous is basically that kind of pink swirly type of connective tissue that typically forms, like for instance, the dermis, the dermal connective tissue in your skin. It also is the main component of scar tissue. So this is basically what's in that periosteal connective tissue. It's going to allow safe passage of things like blood vessels and nerves, things of that nature, so that you can innervate and feed the bone cells that are in the bone itself. The inner layer, which is the cellular layer, is going to contain a couple of things. First of all, it's going to have osteoblasts. That's to lay down new matrix. Typically new circumferential matrix. It's also going to have osteoclasts, and it's going to have osteochondral progenitor cells to basically make new cells. So that's going to be important when we talk about bone repair a little bit later on. So these are basically in that cellular layer. This is the reason why they're oftentimes referred to as the cellular layer, is because it has the cells in there. Now, the important thing is, the reason why the periosteum is important is because since it's collagenous in nature and you've got the collagen fibers in there, what basically happens is the way that muscles like tendons, for instance, attach to the bone isn't like, you take a clean end of a tendon and you just basically glue it onto a bone. What happens is actually, because the periosteum, the outer layer of the periosteum, I'm going to just try to draw it here, is basically, here's my outer layer of the periosteum, is basically full of collagenous fibers. I'm going to write this down here. Collagen fibers. What that basically means is these collagen fibers can interweave, and I'm going to draw a different color here, with the collagenous fibers of a tendon. So basically, this is a tendon of a muscle that's attached to the collagenous fibers of the periosteum. So really, the way that a tendon or a muscle attaches to the bone is not just by kind of like sticking it on there, but it's actually woven into the periosteum of the bone. So this is a really important concept, and it's one that you want to make sure that you get early so that everything else makes sense to you later on, especially in AMP2, when you start talking about, all your organs having this connective tissue outer layer. Remember, when you have connective tissue, you can interface and connect to other connective tissues because you're made of the same stuff. So what's literally happened is the collagenous fibers of the tendon are basically weaving together with the collagenous fibers of the periosteum, basically creating a unified weave or a woven sense to it. So basically it's woven together. The same thing, by the way, is true for your organs. Like, for instance, when you see an organ that has a tough connective tissue outer layer, that connective tissue outer layer will allow that organ to be able to weave into other connective tissue areas to be able to become stabilized. So that's important. So we talk about ligaments and tendons, but this is also true, for instance, like blood vessels, which have a connective tissue outer layer that allows them to be able to weave into these types of tissues and kind of weave it all together. So if you take a look at connective tissue, especially collagenous type of connective tissue, it's not just a matter of support, but it's actually allows you to be able to kind of interconnect all your other types of connective tissues. So with an organ with a connective tissue surface, you can weave into it blood vessels because the blood vessels outer layer is also connective tissue. So you can weave blood vessels into it and innervate or vascularize that tissue. It's a very, very important concept when it comes to understanding how and why connective tissue is organized the way it is in the body. Then we have our perforating fibers, called Sharpie's fibers. And in some periosteal fibers, they basically will penetrate through the periosteum and they'll dig into the bone. And so what these will do is they'll anchor the periosteum into the hard bony matrix. Because remember, at this particular point, all we have is a collagenous connective tissue outer layer, which is busy connecting to other connective tissues like tendons and ligaments and blood vessels and things like that. And on the inner layer, which is close to the bony matrix, it's a cellular layer. So we haven't really figured out a way to keep this periosteal layer connected to the bone, except for these perforating fibers. So these are basically the rivets, if you will, that basically fasten the periosteum onto the bony matrix and keep it from basically sliding off. So then, continuing in with the long bone, on the inside of the medullary cavity is what's called the endosteum. So this is basically typically a single cell layer of connective tissue, and it lines the internal space, the medullary cavity, and also the spongy bone, the cavities associated with the spongy bone. And in this endosteal layer you're going to see osteoblasts, osteoclasts, and you're going to see osteochondral progenitor cells. So the same basic construction as the cellular layer of the periosteum. Only this is on the inside of the bone. Think about it. This makes a lot of sense. So not only do you have a collagenous connective tissue outer layer of the periosteum weaving together with the tendons, the collagen of the tendons and the ligaments and things like that, but you have a cellular layer of the periosteum that's able to lay down circumferential lamellae on the outer portion of the bony matrix. Now what you have is the same construction, osteoblasts, osteoclasts, and osteochondral progenitor cells, which basically give rise or can make new osteoblasts so that you can lay down new bony matrix on the inside layer of the bones. So you have a cellular layer on the outside to lay down bony matrix on the outside of the bone, and you have a cellular layer on the endosteum on the inside of the bone, so you can lay down new bony matrix on the inside of the bone itself. This becomes abundantly important, especially when we start talking about wound repair and bone break healing, the mechanism of bone break healing. So this is our long bone. So first of all, you can see the epiphysis. So the head of the femur is the proximal epiphysis because it's the closest to the midline of the body. And then the distal epiphysis is the one that's down toward your feet. And in between is going to be the diaphysis. That's the main shaft of the long bone. If you were to cut this open, you'll notice that you have this huge medullary cavity in the middle, oftentimes filled with the yellow bone marrow. And on the outside edge is going to be compact bone, that little line of compact bone going down the outside edge. And then around that is going to be a wrapping of periosteum around that. And the epiphysis, you'll notice that you see pretty much all spongy bone. And then at the epiphyseal plate, you'll see in this case, it's not a plate, it's actually a line because it's ossified. You'll see this little line of compact bone that separates these two regions of spongy bone. So that's a cartoon of it. This is kind of what it really looks like. So here's your spongy bone up here. This is that epiphyseal line, and this is your other spongy bone region. This is your medullary cavity, your nice compact bone on the outside, but it's pretty much all open with the exception of yellow marrow inside the diaphysis. And now when you take a look at it, this is basically, we saw this one before, right? So where you can see you have your little circular osteon structures here and here and here. And then you can see your interstitial lamellae in between the osteons. And then, of course, your circumferential lamellae. And then on the inside, you'll see a little bit of spongy bone before you get to the medullary cavity. Now, if you cut this in cross-section, which is what I like, you can see there's a blood vessel going through each of these central canals. There's a little blood vessel going through there, and those are what's called the Haversian canals. And then the lateral canals, these guys right here, is basically the perforating or the Volkmann's canals that connects one central canal to another. That allows for easier distribution of blood throughout this system. And here you can see these little fibers of connective tissue that basically penetrate and dig deep into the bony matrix. That's the perforating or Sharpie's fibers that basically anchors the periosteum to the bony matrix. And then on the inside, you can see this is your inner cellular layer. On the outside, you can see your connective tissue outer layer of the periosteum. So that is basically your long bone. So when you take a look at different types of bones, and this is just kind of like a little bit of an outlier, so I just kind of wanted to throw this in here because there's really no other place to throw it, because we just talked about long bones. That is one type of a bone construction that we see, but we also have different types of bones as well. Like for instance, with flat bones, it's a little bit of a different construction. There's no diaphysis, there's no epiphysis. It's basically a sandwich. It's a spongy bone sandwich with compact bone layers around it. That's the bread. So this is like your cranial bones are like this. They're flat bones. So with short bones and irregular bones, there's typically a compact bone outer region surrounding a spongy bone center, similar to the epiphysis, but there's no diaphysis because they're short and they're not long enough. Some bones, like for instance your skull bones, will have an open space in them, like a sinus, which is an air-filled space, typically full of mucus or lined with mucous membranes. So those are your major sinuses. And a lot of times people will ask the question, it's like, well, what are sinuses for really? So, I mean, like your sphenoid sinus or your frontal sinus or your maxillary sinuses, it's like they're little open chambers inside your skull bones, but like, what do they do there? What are they for? Well, there's a couple of actual there's a couple of things that your sinuses are good for. One of the more interesting functions of the sinus cavities is for pressure equalization. So one of the things that was posited was that our sinuses are actually ways for us to be able to sense pressure changes. Like for instance, if we start to rise or lower in an atmosphere, in the atmosphere, we can sense pressure changes with it. Another important function of the sinus cavities actually that we actually learned from animal vocalizations, and we learned a lot from whales, is it's acoustics. In a lot of animals, sinus chambers in their bones are acoustic chambers. So it allows them to be able to resonate the sounds that they make, like the sound of your voice, through these air chambers. And it kind of creates kind of this sort of reverb. It's like gives you the ability to kind of hear your voice, kind of a thing. Like we always think about, like, well, I can hear the sound of my voice on the inside, but it sounds different than when I hear myself played back, you know. And that's because we hear ourselves as our voice resonates through our nasal cavity and through our sinuses, and it creates like a resonance chamber that allows for vocalization. And so we've seen that actually in a lot of mammals, and probably in part that's what our sinuses are for as well. And of course, they also get infected and inflamed and irritated, and they get sinusitis and things of that nature. So there's also that as well. But there's a couple of different things that sinuses would basically do for us. Okay. So now I want to just get started with bone development, and we'll kind of do the deep dive on bone development next time. But basically, when we start off, we have to start off first of all, and we have to build our skeleton from scratch. And so there's two major ways or major patterns that we see when it comes to ossification. That's really what we're talking about with bone development. We're basically talking about the process of ossification, essentially making bone. So there's what's called intramembranous ossification. Basically, intramembranous ossification is an ossification process that happens inside embryonic connective tissue. Typically, it's a connective tissue membrane. So it's intramembranous, within, which basically means within the membrane. So if you have a connective tissue membrane, then intramembranous ossification happens within that connective tissue membrane. And then you have what's called endochondral ossification. Endo means inside, chondral, the cartilage, ossification. And this is basically happening inside cartilage. So notice you have two different things. You either are happening intramembranously inside a connective tissue membrane, or you're happening inside a cartilaginous tissue that's endochondral. And so both of these typically will start off by producing that cheap woven bone, and then they will remodel, okay? And then after they remodel, it's all the same, right? So basically all terminal bone looks the same. So it's not like you can take a look at a mature bone and say, oh, well, that was made with intramembranous ossification, or that one used endochondral ossification. Because at the end of the day, after you remodel so that everything looks exactly the same. That same structure we just saw with the trabecular structure of spongy bone, or the osteon system, or the Haversian system associated with compact bone. It's all going to look the same after you remodel it. Okay. So let's first of all talk a little bit about intramembranous ossification. Right? This is the one that's taking place inside a connective tissue membrane. And generally speaking, it's formed from embryonic mesenchyme. Remember, mesenchyme is those cells that basically lead to the stem cells in mature tissues. So they're an embryonic type of cell that will become essentially those progenitor cells that we've been talking about. So this particular pattern will form a lot of skull bones, so the flat bones, the mandible, the flat one, and the diaphysis of the clavicles. So it's a little bit different there in terms of diaphysis of the femur and the humerus. Generally speaking, intramembranous ossification is kicking in around the 5th week of embryonic development. And so what happens is the mesenchyme cells will condense around the brain, and it'll form this little, they'll fuse together, and they'll form this little membrane of connective tissue. Now, that's your membrane that you're talking about for intramembranous. And so in it will be very, very thin. They refer to as delicate here. The randomly oriented collagen fibers. Now, this should mean something to you, right? Because we usually use this term randomly oriented collagen fibers as a way to describe woven bone. So you're already kind of setting up a geometrical layout that already looks a little bit structurally in the way it's laid down, like what we see in woven bone, that random orientation of collagen fibers. Now, the next thing we have to do once we lay down the connective tissue is we have to create what's called centers of ossification. These are points, areas in the membrane where ossification begins. Ossification basically means the lay down of bony matrix. And once that starts, then you just continue the process. So a good example, it's a leftover of this process in the skull bones is when a newborn has little soft spots in their head, the fontanelles, right? So these open spaces are large membrane covered spaces where the skull bones have not yet ossified. They're still growing together. But these are connective tissue membranes. That cover the brain. Now, why do we have soft spots? Why don't our skull bones completely fuse before we're born? Trust me, you wouldn't want to have a baby if your baby had fully formed skull bones and sutured skull bones, because there would be absolutely no flexibility in that big old head coming out of the birth canal, right? So the reason why they're only incompletely fused is to create basically the baby's head to be kind of elastic a little bit, so that as it's moving down the vaginal canal, it squeezes through the mother's birth canal, the head can warp and distort without damage because it's still pliable and soft. And basically when it's born, then those fontanelles will basically seal up and close up because they've served their purpose at that particular point. Okay. So what I'll do next time is I'm going to start with taking a look at some of the histology of intramembranous ossification, and then we'll kind of start moving through our ossification patterns as we go. Okay.